Hello everyone, welcome to this presentation about estimating the causal effect of realistic treatment strategies using longitudinal observational data. This presentation is based on the working paper of the same title that I wrote with Alistair and Andrea from York and Noemi from University of Washington. This presentation will go through the background of using real-world data for healthcare decision-making and demonstrate using a case study how to apply the proposed method in a rare disease area to compare the efficiency of various treatment strategies. We will also present some results of treatment effect estimation on patients' mortality and quality of life. So let's get started. We know that real-world data is increasingly important to inform policy decisions in healthcare, including regulatory decisions and health technology assessment. When randomized controlled trial evidence is unavailable, a well-designed real-world study is an acceptable substitute to estimate policy-relevant parameters, such as the average treatment effect. However, confounding bias need to be addressed to produce valid treatment estimates. Confounding can occur when there are variables that affect both treatment assignment decisions and the health outcomes, causing systematic differences between the treatment and the control groups at the time of treatment selection. Time-varying confounding is more complicated, and it occurs in longitudinal observational study when there are variables that are affected by past treatment decisions also influence future treatment and the health outcomes. So targeted minimum loss-based estimation, or TMLE, is a framework for constructing doubly robust, efficient estimators, and it has a few desirable features that I'm going to cover in the next slide. An extension of TMLE to the longitudinal settings, the so-called longitudinal TMLE or LTMLE, have been successfully applied to estimate the average causal effect of sustained treatment exposures. This presentation will demonstrate the use of longitudinal TMLE to evaluate various treatment protocols. So first, let's introduce the few desirable features of the LTMLE. It is doubly robust, meaning that traditional approaches to adjust for time-varying confounding, such as inverse probability of weight treatment weighting, relies on correct specification of the propensity scores model. The parametric G estimation relies on correct specification of the outcome model. Double robust method like TMLE can model both the propensity scores and the outcome mechanism, and provides unbiased treatment estimates if any one of the two models are correctly specified. Moreover, TMLE can incorporate machine learning in specifying prediction models and increase the likelihood of a correct specification. So it's even better than doubly robust. The resulting estimate of, for example, the average treatment effect and the counterfactual mean outcomes have valid estimates of uncertainty, not like many pure machine learning methods that do not produce any uncertainty estimate. Finally, other than the average treatment effect, the model can also produce risk score, risk ratio, and odds ratio if we are studying survival outcomes. Audience is interested in further learning about this method suggested to go to the tutorial paper or the R documentation. Here's an example code and the outputs produced by the package on R. Before we go to the case study, I would like to introduce the concept of dynamic versus static treatment rules. Dynamic treatment rules allow decisions to initiate, continue, or discontinue treatment over time to depend on changing patient characteristics, including previous responses to treatment. Static treatment rules, on the other hand, predefine a sequence of treatments, and the treatment decisions are not based on the current or state or past state of the patient. We'll give you an example of the dynamic and static treatment rules in a minute. The LTMLE method can compare various dynamic and static treatment rules and can compare dynamic rules to static rules. The case study we look at is about myelodysplastic syndromes, or MDS, which includes a group of rare cancers in which immature blood cells in the bone marrow do not mature or become healthy blood cells. The median age at diagnosis is 65 to 70 years old. A European myelodysplastic syndromes registry is a population-based registry that started in 2008 and collects every 6 months detailed patient-specific and disease-specific information of the newly diagnosed patients. These patients are followed up until they die or withdraw from the registry. Our analysis focuses on intermediate 1 to low risk MDS, which account for about 75% of patients at diagnosis. Improvement of anemia and quality of life are the major treatment targets in these patients. Although red blood cell transfusion can temporarily reduce anemia symptoms, they can also lead to transfusion dependency, iron overload, which can cause damage to the heart and other organs. Current guidelines recommend ether or erythropoiesis-stimulating agents as first-line treatment for low-risk MDS patients to delay the need for red blood cell transfusion and to improve patients' quality of life. Although the evidence base regarding the effectiveness of ether in everyday clinical practice and in the elderly population is quite sparse. So there are also variations in the ways that ether has been used in real life. This case study aims to add to the evidence base regarding the effectiveness of ethers by using the LTMLE method we mentioned above before and the registry data to evaluate different treatment protocols of using ether and to evaluate and to estimate the causal effect of using ether on patients' quality of life and mortalities. So this diagram shows how a dynamic treatment rule looks like. Patients start with not having had ether before baseline, and we decide on whether to initiate ether or not based on 2 patient-level characteristics, which are also the confounders we defined in the model. These compared to variables are whether patients are transfusion dependent and their hemoglobin levels. We made the decision to initiate ether among patients who have not received the treatment, and the decision to continue or discontinue ether among patients who have already started the ether at each single time period. The static treatment rule, on the other hand, pre-specifies a sequence of treatment for the patients. Here we only study 2 static treatment rules, which are patients always on treatment or patients always not on treatment. So now I'm going to go through some summary statistics, and the sample we selected are low-risk MDS patients, and after excluding people who missed reported the information on the key variables or in all the visits, we have come up with a sample of 815 individuals at baseline. And among them, we have selected people who follow the rules of never having treatment, or the rules of always on treatment, or the dynamic treatment rule. You can see the number of people on each group declined over time due to either censoring or they no longer follow the rules. This slide gives you a list of variables we include in the model for predicting the health outcomes. And here, this is the treatment variable, and the EQ5D scores is used to measure quality of life. To have a look at the results, when comparing patients always on treatment with patients always not on treatment, you can see that there's no significant difference in either the EQ5D scores or the mortality probability across all the treatment time period. However, for patients who follow the dynamic treatment rule, their EQ5D scores and survivals are generally higher than patients who follow the static rules, which is either always on treatment or always not on treatment. These estimations are all estimated or used superlearners algorithms because it produces lower variance and are more flexible than parametric models. So to conclude, this presentation illustrates the LTMLE method, which can be used to estimate the causal effect of static and dynamic treatment strategies using longitudinal observational data. We focus on superlearner algorithms because it has more desirable features than the parametric models. We find an improvement in patients' EQ5D scores and mortalities among the patients who follow the dynamic treatment rules compared to patients who followed static treatment rules. We thank people who attended the previous presentation of this paper and gave constructive feedback. And the funding of this work comes from European Union's Horizon 2020 research. Thank you very much for listening and have a good day.